Thank you very much. It's a pleasure to be here with all of you this morning. Welcome to Rochester. I hope you have a wonderful week here. You're probably wondering why I'm giving this talk on statistics, and the answer is pretty simple. 16 years ago, when Rick Nishimura was setting up this course, no one else wanted to give this talk. So he said, Chet, you got to give this talk. So I've continued it over the years, and what I'm going to do today is to present an approach to some of the important topics in biostatistics that I think will actually help your practice and give you 2 or 3 easy marks on the board examinations. There are a few questions related to either basic epidemiology or basic biostatistics on the cardiovascular boards, and these should not be difficult. They should be easy marks for all of you. And these are the topics that we're going to talk about. I'm going to quickly review what incidence and prevalence and case fatality rates are. Again, they're simple concepts, but it's important that we think about them clearly so that we don't get mixed up in the heat of an examination. The most important topic, I believe, is diagnostic test interpretation and evaluation. This likely will come up on the boards, and it comes up every single day in your clinical practice of cardiology. We'll talk about how and why we infer significance, evaluation of treatments, and a little bit on how to interpret graphs related to meta-analyses, because these may show up on the boards as well. So the way we're going to do this, and what I'd encourage you to do, is just to pay attention to what's going on the screen here. And we're going to do a series of thought experiments. So I'm going to have you engaged mentally in this presentation all the way through. It's all very simple. It's just high school math, grade school math that we're going to do. And we're going to start with a hypothetical population that we observe over the course of 1 year. This town that we're observing has 1,000 people, and amongst those 1,000 people, 100 of them we're going to say have coronary artery disease, okay? Now, in that town, every year about 10 people die and 10 babies are born. So it's a fairly steady state population. And of these 100 patients with coronary artery disease, 10 of those die, and there are 10 new cases of coronary artery disease that are discovered every year. Either they present with chest pain, infarcts, or whatever. Now let's review some basic definitions. Prevalence is how many people, what proportion of people in your population actually have the disease. So if this question comes up, prevalence is a snapshot. It's how many people in the population have the disease at any point in time, okay? So that's 10%. There's 100 cases of coronary disease amongst this population of 1,000 people. That's very simple. But then the question is, what is incidence, okay? And incidence is the percent of new cases per year. And remember I said there's 10 new cases of coronary disease? So that's 1% of the population. All right, so that's 2 very simple definitions, but it's very easy actually to get those mixed up. Prevalence is a snapshot at a point in time, and incidence is new cases over typically a year that we think about. Case fatality rate is how many of the patients with coronary artery disease are dying, and that's 10% per year. So this is a quick review of these definitions. You should know these cold. Don't get these mixed up on the board exams, because you likely will have at least one question related to this. It should be easy marks for you. Now, let's move on to what I think is the single most important thing in biostatistics, not only for the boards, but in our day-to-day practice. And what I'm going to give you is a framework within which clinicians can understand this stuff. Now, I'm not a biostatistician, and I have always found it difficult to think in terms of 2x2 tables, which is typically the way this stuff is taught in medical school or college-level statistics courses. So we're not going to go through 2x2 tables, but we're going to do, again, a series of thought experiments, and you're going to walk through this with me. Now, why should we think about diagnostic test interpretation? I think the most important reason, it's very important in your clinical practice. If you understand this stuff, you'll be a better cardiologist, and it'll keep you out of trouble, out of medical legal trouble, if you understand how to use and interpret your test better. Second, in cardiology, we have a plethora of wonderful tests that we can order. We have all sorts of functional tests, all sorts of imaging tests and invasive tests. And we need to, not only do we need to know how to do them, but we need to know how to interpret the results and put them in the context of our patient. And I think that tests, I feel strongly about this, that tests should serve our clinical practice and not the other way around. We should not be chasing tests, but rather they should be helping you practice cardiology. So let's dive into this. We're going to, again, do a thought experiment. Now, let's say you're a cardiology trainee someplace, and you're not doing so well in atypical chest pain. So your program director says, you've got to spend 1 year in atypical chest pain clinic. And that sounds like fun, right? Now, let's say over that 1 year, you see and evaluate 1,000 patients. We're going to use nice round numbers here. It's all mental math we're going to do. And over the course of that 1 year, you will order a functional test on all 1,000 patients, okay? Now, let's assume in that 1,000 patients, within those patients, there are actually 100 patients with coronary artery disease, right? Now, you as a clinician don't know who they are. They don't walk into your office stamped with coronary artery disease. It's your job to figure that out. But so right here, the prevalence, as I said in the first example, the prevalence of disease is 10%, and this is really important. Now, you order a functional test, and I'm going to say, I don't care which functional test it is. You can order an exercise study, a pharmacologic study, you can use whatever imaging you want, or you can do it without imaging. They're all excellent tests. In fact, I'd say if your non-invasive laboratories aren't doing excellent tests of a high technical quality, they shouldn't be doing them at all. So let's just stipulate that the sensitivity is 90% and the specificity is 90%. Now, these are terms I bet you've heard since medical school. And I bet that many of us are still somewhat confused about these, particularly about specificity. So I'm going to explain these to you and explain how we use them, all right? So it's an excellent test. We're going to say it's 90% sensitive, 90% specific. So let's walk through this. We're going to now analyze these 1,000 patients in the atypical chest pain clinic. So the first question relates to sensitivity. How many patients with coronary artery disease will you pick up? Someone yell out the answer. 90. So we're going to pick up 90 of the 100 patients because that is the definition of sensitivity. Okay? It's how many patients with disease return a positive test. So the converse of this is, how many are we going to miss? Answer? 10. Very simple. So this is 10. This is the false negative rate. But, you know, rather than thinking false negative, I'd ask you to think about how many are you going to miss? Because this is what's important to us clinicians. Now, let's think about the other patients, the other 900 patients without disease. Of those patients, how many are we going to correctly rule out? Someone yell out the answer. 810 is the correct answer. And now this is sometimes confusing. This is specificity. This is of the 900 patients without disease, how many are we going to correctly rule out with a negative test? That is specificity. 810 get ruled out. The converse of that is how many false positive tests will we have? And that's the other 90. Okay? So 90 is the false positives, and this is a function of specificity. So it's actually pretty simple, I think, if you think about it in this clinically oriented way. Now, remember I said your job as a clinician is to ferret out which patients actually have disease and which patients don't have disease. Okay? So you as a clinician get a test result. You get an electronic result or a piece of paper that says it's positive or negative. Now, you actually don't know whether it's a true positive or a false positive or whatever. You just have a positive and a negative. So the question is, what are the predictive values? If you're holding a positive test in your hand, let me ask you now, think about this. What is the positive predictive value? So if you get a positive test, what's the chances that it's going to be correct, that it's going to be a true positive? Very good. Of the 180 positive tests, only 90 of them are actually going to be true positives. That's 50%. So if you get a positive test, there's only a 50% chance it's correct. Now, what about the negative predictive value? What do you think there? So we had 820 negative tests, and of those, 810 are correct. That means the negative predictive value is 99%. Okay? So what this is telling you is that you have a negative test, there's a 99% chance it's correct, patient doesn't have coronary disease. But let me remind us, just what was the likelihood the patient didn't have coronary disease just as they're walking into your office? It was 90%, right? Because only 10% had disease. So I would challenge whether this test actually helps us in this situation. So let's keep this example in mind. We're going to turn our attention, we're going to go to the other extreme now. So now the second year of your fellowship, you get put into the coronary care unit. You spend a year in the coronary care unit, and you see 1,000 patients with typical chest pain syndromes that are presenting as inpatients, and you order the exact same functional test on all 1,000 patients. Okay? The difference this time, obviously, is that because it's the coronary care unit, typical symptoms, we're going to stipulate that 900 patients amongst these 1,000 actually have coronary artery disease, i.e., the prevalence of disease is 90%. All right? So let's run the exact same test in this population and see what happens. So, of the 900 patients with coronary disease, how many will you pick up? What do we think? Anyone? 810 we pick up, which means that we will miss the other 90. Okay? This relates to sensitivity. Now, of the 100 patients without disease, how many will we rule out correctly? "90", because specificity is 90%. And in this case, the false positive rate will be the other 10 patients. So only 10 false positives this time. So now let's think through the predictive values, which is what you and I actually have to work with as clinicians. So somebody think about this and tell me, what is the positive predictive value? Of all these positive tests, how many are actually correct? Almost all. It's 810 out of 820 are correct. Okay? Almost all. And what about the negative predictive value? And remember, if you're working in an emergency department, typical chest pain, if you get a negative test, you as a clinician have to make a decision what to do with that patient. Do you send them home? Do you admit them? What do you do with them? So this is really important for your practice. The problem is the negative predictive value is terrible. It's only 50%. So can you send a patient home from the emergency department with that type of negative predictive value? You're going to be hearing from lawyers very quickly if you do that. So this negative test, which was an excellent test, it had 90% sensitivity and 90% specificity, but applied in this patient population can set you up for trouble as a clinician. And the reason is the negative predictive value is only 50%. So again, I would challenge us to ask the question, is this test, which is a good test, is it really helping us? Now, so far, the two hypothetical populations I've shown you, it's questionable whether this test has helped us. So what's wrong with it? What's going on here? So let's do a third population now. This time, we're going to see patients in the cardiology outpatient clinic. These are patients referred to you by family docs and internists who have sort of anginal sounding pain. It may or may not be angina. And we're going to see 1,000 of these patients over the course of 1 year. Now, let's run the exact same functional test on these 1,000 patients. But this time, I'm going to give you a population that has a prevalence of disease of 50%. So you're going to now deal with 500 patients with disease and 500 without disease. So let's do the same questions again. You're used to these now. Of the 500 patients with coronary disease, how many are we going to pick up? Anyone? Don't hear it. 450. Okay? 90% of those are going to get picked up correctly, which means we're going to miss 50. Now, of the 500 patients without disease, how many are we going to correctly rule out? Anyone? 450, because it's 90% specificity, which means the false positive rate or number is 50. Okay? So it's a little different than the other two populations. Let's think through now what the predictive values are, and I want you guys to tell me what they are. So what is the positive predictive value? So we had 500 positive tests. What's a positive predictive value? Yeah, 450 of those tests are correct, which means the positive predictive value is 90%. So that's a number that you and I can work with as clinicians. Now, what about negative predictive value? What's the rate there? What's the negative predictive value? With 500 negative tests, 450 of them are correct. So it's a 90% negative predictive value. Again, that's a number that we can safely work with. Now, so think about what we've done here. These are very strong numbers, and these are numbers that you can safely work with. We haven't changed the test at all. Okay? We've not changed the test. So what have we done? What did we change in these three populations? Yeah, the only thing we changed is the prevalence of disease. Okay? So we went from the low prevalence population in atypical chest pain clinic to the high prevalence population in the coronary care unit to the medium prevalence population in the cardiology outpatient clinic. And this is a table you'll find in your syllabus that just gives all the values. So what is this? What is this called? This is Bayes' theorem. This is Reverend Bayes' theorem. And what it says essentially is that the post-test predictive value of any test is dependent upon the pre-test likelihood of disease. Now, this doesn't hold true just for exercise testing. This holds true for every test we use in medicine. Okay? So if it's an echocardiogram for mitral regurgitation, the interpretation of that should be influenced by your clinical examination and your clinical impression. So for any test in medicine, whether it's a CT for pulmonary embolism, your interpretation of that CT has to be informed by your pre-test likelihood of disease. And we'll talk about how you come up with that. So this is the way these are typically portrayed. On the x-axis, we have the pre-test probability of disease, and on the y-axis, we have what happens with a positive or negative test. So with a low prevalence population, with a 10% probability, a positive test takes that likelihood up to just 50, and a negative test drops it to 1. Similarly, with the high prevalence population, a positive test almost certainly includes rules in patients, but a negative test does not let you exclude patients, does not let you rule them out. It's really in this mid-range where these tests really help you. So this is a sort of patient where you've seen them in the examination office and you think, yeah, it could be angina, but I'm not quite sure. If you run a test on that patient, it'll help you make up your mind. And this is where these tests are most useful. So just a few points that I think you ought to remember for the boards as well as your clinical practice is that the only difference amongst these three populations was the prevalence of disease. We made no change whatsoever in the clinical performance of the test. It's not the test, it's the patients. So I would argue that the single most important thing in diagnostic test interpretation is your estimate of the pre-test probability of disease. So how do you come up with that? And I would say this is your clinical judgment. This is your history-taking skills, and for valve disease, it's your physical exam. But for angina chest pain syndromes, it's primarily your history-taking skills. You as a clinician should take a history and then come up with a sense of whether a patient has low, medium, or high likelihood of disease, or very low and very high. And any one of us in this room can do that very quickly. In those 5 categories, and that's all you have to do. If the pretest likelihood of disease is very high, I argue there's no point doing a functional test, because a negative test isn't going to let you send that patient home from the emergency department. And similarly, if it's very low, I don't think that a positive test is really going to help you rule in patients. You're going to end up cathing them anyways. So it's really when you as a clinician think it's in the medium range that these tests help you. And as I summarize here, diagnostic tests are most useful when there's uncertainty in your mind after you do your initial evaluation. Now, I often get asked, what's the single most important number for a test? Okay? It's not sensitivity, it's not specificity, it's not predictive values. The one point I want to make about predictive values is that tests do not have predictive values. So if you're ever reading a paper that says test X has a predictive value of such and such, you shouldn't read that paper. The way they ought to word it is that test X applied in this population has a predictive value of Y. Okay? So predictive value comes out of the sensitivity and specificity of the test and the prevalence of disease in the population. You cannot have one without the other. So keep that in mind as you read the literature. Now, the next couple of slides are not relevant for boards, but if to answer the question, what is the most important number for a test, it's something called a likelihood ratio, which is the ratio of sensitivity over 1 minus specificity. So for the examples we were working with, 90% sensitivity over 1 minus specificity gives a likelihood ratio of 9. So this is a very powerful test. The higher this number, the more powerful the discriminatory value of the test. And that's basically what a likelihood ratio is. I just wanted to define it for you so that you understand it if you ever come across it. The higher the likelihood ratio, the greater the discriminatory power of the test. Now, it's interesting that tests are not all the same, and they're not just positive or negative. They're often very positive or stone cold normal, right? We all know this. If you're doing a stress test on a patient, there's a difference between a stress test that has 1 millimeter of ST segment depression and 3 millimeters of ST segment depression. So the likelihood ratio allows us to actually quantitate differences in the magnitude of positivity of these tests. So it's useful from a biostatistical purpose and allows us to understand how to interpret these tests. Now remember, I talked about history-taking skills. Now, taking a good history is actually a diagnostic test. So if somebody gives you a story of typical angina, which is exertional chest pain that's relieved with rest or sublingual nitroglycerin, if it's typical sounding, that history has a very high likelihood for epicardial coronary artery disease, which is why you don't need to do another test just to answer the question whether or not you should take them to cath. Okay? So keep that in mind. A well-taken history or a good physical exam for valve disease or heart failure is a diagnostic test in and of itself. Now, this next thing is a very important thing for understanding the literature. You will recall that in our coronary care unit, we figured out the negative predictive value of all those negative tests we had was only 50%. Remember I said you can't really send patients home from the emergency department with a negative predictive value of 50%. But let's say we do that. We send these 180 patients home. Now, they're not going to all go out and die tomorrow, right? They're going to go out, and some of them are going to have events over the ensuing few months. Let's say over the next 3 months, 30 of them, only 30 of the 90 false negative patients actually come back to the emergency department, right? So in other words, you as a clinician only see those 30 patients who've come back. Then you as a clinician are going to think in your mind that the negative predictive value is actually 150 over 180. In other words, 83%. Right? So this is something called verification bias, and it's rampant in the literature, and it makes these tests look much better than they actually are. And the reason is that we don't necessarily find out about when we're wrong. So keep this in mind. Unless there's a gold standard test being performed, like angiography in the case of coronary disease, we're very susceptible to verification bias. for diagnostic tests that we are ordering and interpreting. Now, the next thing I think also is important for your clinical practice and for boards, I think. And this is screening tests, okay? So screening tests are exactly that. They're done in large masses of populations to try to pick up patients with disease so we can intervene earlier, okay? So let's do something here. We'll do another quick thought experiment. Let's say that you're going to set up shop to screen a low prevalence population for coronary disease. And so these are going to be ambulatory patients with 2 or 3 risk factors. It could be smokers, diabetics, whatever. But they're not symptomatic right now. They're ambulant. They're fine. The prevalence of disease is probably going to be about 5% in that population. So they come to your new center, screening center, and you're going to do a very sophisticated test. You're going to go in the back room, you're going to flip a coin, right? Now, if it's heads, you're going to go out and tell them that they have disease. If it's tails, you're going to go out and tell them there's no disease. So my question for you, and I'd like you to use the audience response system here, is what is the negative predictive value of tails? Do we have the ARS up? There we go. Good. So 60% got it correct. 40% didn't get it correct. So this would be, this type of mix would be a good board question. So let's think about what we've done here. So is this actually any sort of useful diagnostic test? No, it's not. It's just flipping a coin, right? But the way to think about it is, what's the negative predictive value of the patient just walking in your office? What's the chances they don't have disease just walking in your office? 95%, right? Because 95% of them don't have disease. You flip a coin, which is meaningless, and at the end of that, 95% of them still don't have disease. But you can assuredly tell them, and it's the truth, that with this test, that there's a 95% likelihood you don't have disease. Seems powerful? You can charge a lot of money for a test that powerful, right? So when you see, or when you see marketing claims or you read studies that say the negative predictive value of such and such screening test is 97%, 98%, that is not impressive. That really is not impressive, because the vast majority of these patients don't have disease just walking into your office. But you can charge a lot of money for that. So to summarize, what I think is the most important thing about biostatistics in cardiology, and that is diagnostic test interpretation. First, I think if we ask the questions in a clinically relevant manner, we'll understand this and we'll be able to intelligently apply these very basic concepts in our clinical practice. I hope I impressed upon you how important your individual clinical judgment is. Okay? Cardiology is about clinical judgment, not just about ordering tests. And we should never interpret tests in isolation of our clinical judgment. And I've just shown you an example where any test, no matter how poor, when it's applied in a low prevalence population, will have an absolutely outstanding negative predictive value. Don't get misled by that. Next, verification bias makes tests look better than they really are. And again, the bottom line here, tests are really useful when you need them. So I hope that's given you, a framework to consider diagnostic tests, not just in coronary disease screening or evaluation, but in all of medicine. Okay? Now, for the next few minutes, what I'm going to do is to move on to some of the other topics that frequently come up, and the next one often comes up. And this relates to inference of significance. So I'm going to ask you a question. What does a p-value of p equals 0.05 really mean? So we're going to use the ARS here. Does it mean that the results of the study you're reading have a 95% chance of being significant? Or does it mean that the probability the results are correct is 95%? Or does it mean that the probability the results are wrong is 5? Or that the results could be a fluke by chance, but that the probability of that is only 5%? So take your time, think about this, and tell me what you think. Very good. Yeah, this is exactly right. It does not tell you that the results are significant or that they're correct. It does not tell you that. What it tells you is that it could just be a fluke, but that the chance of that is 5%. So if you think about it, of all the studies you see with this p-value, okay, 5% of them are a fluke. So if you're reading 100 studies, 5% of them are significant just by chance. And this is why it's important that studies are replicated, okay, for verification that they really are correct. So remember, this is a really important concept, and we often get misled, particularly in subgroup analyses. So let's say you do a trial, and you do 100 subgroup analyses. How many of them are going to be significant just by chance? Probably 5%, right? So be very careful with subgroup analyses. The question is, where does this 5% come from? I mean, who decided that? It's arbitrary. It could be 6%. Why not 6%? And why is it 5%? Well, it comes from Professor Ronald Fisher, who was one of the most eminent and influential biostatisticians of all time. He was also a famous geneticist. He was a polymath who worked in 2 different fields. And he's the one that developed Fisher's exact test, and there's many other tests in biostatistics that are named after him. And he selected this arbitrary cutoff value because in the early 20th century, it made it easier to do slide rule calculations. So, you know, this is, as far as I can tell, this is the root of where 5% comes from. So there's nothing magic about it. It's arbitrary. I actually think 0.01 should be better, would be better than 0.05. But this is what science has selected, is 5%. Now I'm going to turn our attention now a little bit to interpreting these type of graphs and assessing therapeutic effect of our treatments. So this is a meta-analysis. Okay, we all see meta-analyses every day now at the meetings and the literature and talks, and you may well be confronted by a graph such as this, and you need to know how to interpret them. Typically in a graph such as this, on the left, whatever treatment is being tested is placed, and if the dots or the lines, the bars line up on the left, that means your new treatment is better, and that the control group or the previous treatment is typically on the right. In the center, the y-axis is usually the line of unity, and the way to interpret these is that the lines, these are called 95% confidence interval lines. If these lines cross the line of unity, then this study is not significant. Okay? Usually at the bottom, they have a summary where the statistician has summarized all the individual trials into one meta-analysis, and if the 95% confidence intervals of that summary graph here, if they're all to the left of the line of unity, then it's a statistically significant meta-analysis or a positive meta-analysis. So don't, when you see these type of graphs, don't be intimidated by them. They're actually easy to interpret. Now, I'm going to use this as a case example on how to interpret therapeutic effect. This is from the old literature of thrombolytic therapy, looking at randomized trials of lysis for myocardial infarction versus placebo. I mean, we would never consider this now, but these were some of the trials that established reperfusion therapy as standard of care for acute myocardial infarction. And what this meta-analysis showed is that of the 14,000 patients treated with lytic agents, 8.8% of them died, and of the 14,000 treated with placebo, 11.6% died, right? So here's the graph. It's clearly positive, and fibrinolytic therapy was accepted in the cardiology community worldwide as standard of care. Now let's think about these numbers. We said the placebo mortality was 11.6% and the lytic mortality was 8.7%. So is this a big treatment effect? Well, this is a 25% relative risk reduction, okay? So 8.7% is 25% less than 11.6. And that's it. It's simple. This is relative risk reduction. But you and I as clinicians don't actually work with relative risk. We work with real-life patients, one at a time, and so what's important to us is absolute risk reduction. And this is the difference. That's all it is. The absolute risk reduction between this number and that number is 2.9. So this is actually the true strength of this treatment. The number needed to treat is a very commonly used metric for this, and it's basically how many patients do you have to treat to save one life. And if you think about this, it works out to 34 patients you'd have to treat with a lytic agent to save one life. So that's quite a few patients you have to treat, right? The other 33, probably not helping. In fact, you're exposing them to some risk, but you're not really saving their life. The way I like to think about these, just for nice round numbers, is the number of lives per 1,000 patients treated that you're saving. So for lytic agents, for this example, it works out to 29 lives for 1,000 patients treated. And that's a realistic number.